Dr. Chris, and today I am reacting to the Ryan Villopoto St. Louis crash. Generally, it is not a good idea to jump off a motocross bike when it is already 15 feet in the air. Ryan Villopoto, former professional motocross rider, and his 2010 leg injury are going to help us to understand the reason why. Thank you, Ryan. Hey everybody, Dr. Chris, orthopedic surgeon and sports medicine physician. If you are here because you subscribed after watching my videos on Ken ROCZEN, Adam Cianciarulo, or Eli Tomac, then thank you for becoming a part of the intern army. Brah! Welcome to my channel, where I explain orthopedic injuries and sports medicine in a way that's easy to understand for everybody.
Ladies and gentlemen, can I please have your attention?
Now, I would focus and I would dig as deep as I can.
Today I'm talking about Ryan Villopoto and the injury that he sustained on April 18, 2010 during round 14 in St. Louis. While leading in the main event, Villopoto attempted a different line on a triple jump than had been used by other racers earlier on. Previously, racers had kept to the left-hand side of the track when traversing this triple jump. However, here, Villopoto decided to approach the triple jump from the right-hand side. Unfortunately, he came up short on the jump and he was forced to make a choice. Either stay on the bike and endo into the crest of the third jump like a dirt missile, or bail from the bike while it was still in the air, hoping to clear the jump with his body and land onto the ground beyond the jump. Villopoto chose the latter option. This was probably the better of the two options available, but he didn't exactly win. He hit the ground at speed on his left side in a semi-sitting position. Fortunately, he did not strike his head or lose consciousness. Unfortunately, however, he did not get up, and it was clear from his body language that he was in a world of pain. Villopoto was quickly attended to by the medical staff, who cut off his boot trackside. More on that later. He was carried off the track by the medical staff. Subsequent medical examination revealed a fractured right leg. Ryan was taken to the hospital in an emergent fashion where his fractures were stabilized surgically. He was forced to withdraw from the 2010 series as a result of his injury. At the time that he withdrew from the championship, he had already accumulated 266 points, and despite his inability to complete the season, this was enough for him to finish in 4th place by the end of the season. So how did Ryan Villopoto injure himself in this motocross crash? What are the injuries that he suffered? How were his injuries treated? And was this treatment the only option? How did his physicians decide what treatment to use? And how did his injuries affect his future in motocross racing?
Teach's first ever race in MetLife Stadium, Ryan Villopoto.
Villopoto, realizing that this jump was not going to end well, bailed from his bike while it was still in the air. He sailed through the air in a seated position, traveling legs first. He struck the ground on his left side with his right leg extended slightly further than the left. The impact with the ground on the inside aspect of his right foot caused a sudden bending force to be applied to his right lower extremity. This force resulted in a fracture of the lower extremity at the level of the tibia. And this just means that he broke his lower leg because it was smashed against the ground sideways. Bazinga! Bones are great in compression, but they really don't like rotation or bending. Villopoto was examined trackside by the medical team. They cut his boot off so that they could examine his lower extremity. They determined that there was clear instability of his lower extremity. Normally, we advocate not removing the boot or shoe at the scene of the accident, since the boot or shoe can function as a splint for the injured extremity, and they can help to control swelling to some degree. We typically prefer footwear to be removed in the hospital setting, where we have supplies available to support and stabilize the injured extremity should it be required. Villopoto was transferred to the hospital for further assessment. Radiographs of his right lower leg confirmed a significant fracture. In a November 2010 interview with Racer X, the interviewer stated that Raynor had suffered fractures of his right tibia and fibula and a broken ankle as well. This suggests that he suffered a fracture at the level of the ankle as well as higher up at the level of the tibial diaphysis or the tibial shaft. If there was an extension of the fracture line between these two fractures, this would be described as a comminuted fracture pattern, or a fracture involving more than two fragments. In that same interview, Ryan revealed that he underwent several surgeries over a period of 1 month, suggesting that the fracture pattern was complex in nature and not amenable to treatment in only a single setting. He also revealed that the first surgery in St. Louis involved the placement of an external fixator frame shaped like a halo. This frame is known as an Ilizarov frame, and it is used primarily in 2 settings: open fractures and fractures with extensive comminution or bone loss. Its use in Ryan's case suggests that his fracture was either an open fracture with the bone sticking out through the skin, a fracture that was very fragmented with very many small bones, or a combination of both of the above. Either way, it was not good. We know that his fracture was serious and complex because its fixation required several surgeries to achieve definitive stabilization. This is a significant amount of damage from such a simple accident. So how were Ryan's injuries treated? Although I do not have access to his actual radiographs, if I piece together the information above, I can come up with a plausible scenario which follows. In the accident, Villopoto suffered an open fracture of his tibial and fibular shafts. These fractures were associated with a closed fracture of his ankle on the same side. The tibial fracture was likely significantly fragmented and had a relatively large associated wound. This fracture pattern requires immediate treatment to prevent complications such as infection and non-union. In the initial surgery in St. Louis, Ryan would have undergone an irrigation and debridement of the open fracture and his wound. This simply means that the fracture and the wound would be washed out with a large volume of sterile fluids to clean out dirt and wound contaminants. Wound edges would be cleaned up to remove damaged skin that might subsequently die. Ryan would have also received intravenous antibiotics to prevent infection and tetanus toxoid to prevent tetanus or lockjaw. The fracture would have been provisionally stabilized with the Ilizarov frame to provide time for significant soft tissue swelling around the fracture to settle and to ensure that there was no evidence of infection before definitive fixation was applied. Approximately 1 week after this first surgery, Ryan underwent a second surgery, this time in either Seattle or California. Here he would have undergone another irrigation and debridement and likely a stabilization of his ankle fracture with a fibular plate and screws, leaving the tibia fracture still stabilized by the Ilizarov frame. The frame would be inspected to ensure wires were secure and that there was no evidence of pin site infection or infection where the wires entered the skin. 1 week later, a third surgery would be performed when the surgeons felt that the skin had settled enough to ensure full closure of the operative wounds. In this surgery, the Ilizarov frame would be removed and the tibia fracture definitively stabilized. In the Racer X interview, Ryan stated that eventually, after 3 surgeries, the fracture was fixed using plates and screws. A separate article in ultimatemotorcycling.com states that he underwent 2 lengthy surgeries, one lasting 6 hours and the other lasting 8. At any rate, ideally, tibial fractures are fixed with intramedullary rod fixation, where a titanium rod is inserted down the middle of the tibial shaft and locked at its top and its bottom with locking screws. However, in some cases, such as where there is extensive bone loss or where the tibial shaft fracture is quite close to the joint surface at the level of the ankle or the knee, a titanium rod may not be used. In these cases, low contour dynamic compression plates or pre-contoured plates are used instead. These were used to fix Ryan's tibia fracture. These implants would offer less compression and less stability than would an IM rod, but they would provide better control of fractures that were close to the joint. Ryan's comments about the prominence of the plate under the surface of the skin lets us know that the plate was positioned on the medial aspect of the tibia, or the inner side of the tibia close to the level of the ankle, where there is not much soft tissue coverage. This leaves the fixation prominent under the skin and easy for patients to feel, unfortunately. Among other things, this is one of the drawbacks of this type of fixation. However, with the fracture pattern that his surgeons likely faced, when life gives you lemons, you make lemonade. Following his surgery, Villopoto told UltimateMotorcycling.com that he had been advised by his doctor that it would take 12 weeks to be able to walk again, but that he was planning for this to occur in only 8 weeks instead. Unfortunately for Ryan, his early exit from the 2010 Supercross series left him unable to score points in the last 4 Supercross events and unable to challenge Ryan Dungey for the 2010 Supercross Championship. Ryan returned to racing for the 2011 Monster Energy AMA Supercross Championship, where he won 6 races and narrowly defeated Chad Reed in the 17 race championship by 4 points to become the 2011 Supercross champion. He repeated as champion in 2012, 2013, and 2014 before electing to compete in the FIM Motocross World Championship in 2015. Not too freaking shabby. If you enjoy what I do and the information that I provide, then you can support what I do by either becoming a member of this channel or by checking out my Patreon page, where you'll be able to access additional content and interact with me more closely. YouTube does not seem to like injury videos, and my videos are often demonetized. If you enjoy podcasts and you haven't already, be sure to subscribe to my new podcast channel. The link will be down in the description below. And if you're looking for exercises and workouts, or you want information on injury prevention, be sure to check us out on our sister channel here on YouTube at Human 2.0. Thanks for watching. As always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.